What would you consider a success? First, somebody's getting an epidural for the first time. What would you consider success versus a failed epidural on trial one?
And we talked about this with the patient too. We want to see, we have to measure pain scores. That's all we got. It's subjective. But we say, listen, we're looking in general for injections or anything we're doing interventionally on the spine or in the whole body. We just want to see usually at least a 50% decrease in pain. That seems to be successful where, you're 8 out of 10 of the pain. And if we can get you at 50%, that's 4 out of 10, that more than doubles your function theoretically, right? And for us, it seems to justify the risk-benefit ratio of doing that, which is very different than medications, for example. So we're looking at, decrease in pain, increase in function. And then the big thing with the steroids is duration. Are we getting at least 2 or 3 months out of it? We get a lot of results where maybe they only last 2 weeks, 3 weeks, and it goes back. People have different responses to the steroid. And so that's sort of our outcome factors. And that also can necessitate how frequently we can repeat the steroid injection without harming the body.
What does the first couple of days tell you about a steroid injection? I've had patients that obviously you and I are co-treating or, are doing both my therapy and an epidural. And normally I'll see them a couple days after, and a lot of times they're looking at me going, it didn't do anything. Should they be worried at 2, 3, 7 days if they feel no different?
No.
Okay.
No, the physiology of the steroid on the body, in general, it takes 3 to 10 days for that anti-inflammatory effect to fully kick in. Some patients feel relief on the first day. We always tell them it can take up to 2 weeks. So we'll schedule a follow-up with them in about 2 weeks. So we know that the steroid has fully run its course. The steroid stays in the body for about 2 weeks. And we know at that point the adrenal glands have kind of normalized, and we can see if the effect is lasting longer than that.
Yeah, it's something that's a hot topic in here a lot because they're like, man, that didn't work, and I just spent all this money, and I just da-da-da-da-da-da-da-da. And I normally have that same conversation with them. I'm like, you're not going to leave there 100%. Give it a week, give it 2 weeks, and then see where you're at. Is there a limit nowadays on how many patients can get per body region per year? Is that how that works?
There's a lot of probably confusion surrounding this, in my opinion, because there's a lot of patients say, I don't want a steroid because I don't want to have weight gain. I don't want to have a steroid because it weakens my bones. All true. I think it's important to tell the patients, and this is what we tell them, is the dose is the cure and the dose is the poison.
Right.
So it all matters, like how frequently, how much is what's happening. So if you're on oral steroids chronically, it can be very problematic. We know very clearly defined outcomes that are negative on the body with chronic oral or even injectable steroid use. Very bad. Short term, it can be highly effective for treating the complex interplay of pain, which is an interaction between the immune system, the nervous system, the endocrine system. And we've been using this steroid for, over 50 years now in these injections. But, frequency for us, what I say is the steroid's in your body for about 2 weeks. And then your adrenal glands normalize within usually about 2 months. So for us, I say, and we should tell patients should know this as well, no more than probably 5, max 6 steroid exposures on a rolling 12-month basis. Because they'll come in, they'll see us, they see their orthopod, they get an injection, they go see rheumatology, they get an injection. And we're not tracking it. We don't necessarily get all the rheumatology notes, for example.
Right.
And before you know it, they're getting overdosed on their steroid and they have a problem.
Spine, steroids, you're doing obviously the injectable. Oral versus other ways to dose this. Could an oral have a significant lasting effect, improvement-wise, on spine?
Yes, it can. Yeah. And we'll do that for patients. A classic example of that, somebody comes in with like a hot disc. We just had a guy, a fireman, come in, huge herniated disc, didn't have any imaging. We can't just take you back and put a needle in there without looking at the spine at least. So let's at least get you an oral steroid pack. It's going to be systemic, but some of that will circulate to where the pain is still going to be a systemic anti-inflammatory effect, which is what we're looking for.
Yeah.
And in that situations, we will give them a steroid pack.